As physician members of this critical task force, you're essentially the mission control for our neurology residents. In this explainer, we're going to decode your operational parameters and make sure you've got all the exact coordinates you need for a totally successful mission.
Every 6 months, our residency program must process hundreds of individual performance metrics into a single, coherent signal. The output of this system is critical, verifying that each resident has achieved the clinical autonomy required to practice neurology safely. As a member of the Clinical Competency Committee, you are the operators of this engine. The ACGME requires us to move past subjective impressions and informal observations. We are tasked with taking disparate streams of clinical feedback and synthesizing them into an objective trajectory of a resident's growth.
We use it to document a resident's entire journey, moving sequentially from a true novice to a highly capable clinical expert.
To maintain this system, the committee operates on a strict semi-annual cadence, convening every May and November. When we gather for these sessions, our time is reserved entirely for high-level synthesis and final consensus. These meetings are not the place to open evaluations for the first time or discover missing data. The entire process stalls unless every committee member completes a rigorous review of their assigned files long before taking their seat at the table. Preparation is the fuel for this engine. We cannot synthesize data that hasn't been properly pre-processed. Your work begins by logging into the new Innovations portal. Here, you will pull the first vital set of data, the residents' clinical rotation evaluations. Next, you need to review their objective medical knowledge through their in-training exam scores. Then, check their clinical conference participation metrics. Finally, verify their documented scholarly activities and research output.
By utilizing this non-linear telemetry, we track genuine clinical growth. This prevents us from making premature graduation decisions based entirely on the calendar.
You are assigned a specific cohort of residents, and you must run each one through this exact intake checklist. Only after this raw, unstructured data is fully gathered can we begin mapping it to the official ACGME framework. We calibrate this raw data using the official ACGME neurology milestones. This matrix operates on a 5-level developmental continuum. Critically, these milestone levels do not strictly correlate with a resident's postgraduate year. Depending on prior clinical experience, a junior resident might surge ahead to level 3 early in training. Conversely, a senior resident might stall or drop backward on the matrix if they struggle with a specific skill set. Level 1 represents an absolute novice, the baseline expectation for a resident entering the program. Level 4 serves as our critical threshold. This is the functional target required for graduation and unsupervised practice. Level 5 is an aspirational state, representing an expert resident who exceeds the expectations of the subcompetency. This architecture requires us to evaluate the resident's current, proven abilities, rather than assuming competence based merely on their tenure in the program. Let's apply this mapping to a concrete clinical scenario.
Looking at the Patient Care 1 History subcompetency, a Level 1 action is defined simply as obtaining a basic neurologic history. The Level 4 target for that same subcompetency requires performing a hypothesis-driven, complete, and organized neurologic exam. And a Level 5 rating means they are actively serving as a role model for clinical reasoning in complex presentations. Once you determine where the resident's performance falls, you must record this on the official documentation. This diagram shows the official ACGME report worksheet. Notice the response boxes below the descriptions. Selecting a box dead center in a column means the resident has substantially demonstrated the milestones in that level and all lower levels. Alternatively, selecting the box on the dividing line indicates lower levels are met, along with some milestones in the higher level. Applying these scoring mechanics precisely eliminates ambiguity, yielding an airtight evaluative record for the committee. As assigned reviewers, your job is to evaluate the evidence and locate the resident on this exact continuum using the official ACGME grid.
When every member executes this process, the engine produces a clear, objective trajectory for each resident. The program director relies entirely on this empirical evidence to make high-stakes determinations. These reviews directly govern whether a resident advances to the next year, requires formal remediation, or is cleared for final graduation. Therefore, your immediate directive is to log into New Innovations and review your assigned data packets. Every single assigned milestone evaluation must be fully completed and submitted before we convene. This pre-work is strictly due exactly 2 weeks prior to the May and November CCC meetings. This 14-day buffer is structurally necessary. Our program coordinators require that exact window to compile the raw scores into the final reports we review as a group.
When we gather for the CCC summit, our meeting time is strictly for building final consensus.
This administrative discipline is how we uphold the standards of the neurology specialty and ultimately protect our patients.